Right. It's a minute past. And finally, the glorious English summer is here. It's warm. The sunshine feels just mesmerizing. And it's that time of the year when almost everyone wants to be out with families and friends and loved ones. You want to be out for barbecues. You want to be out for a walk. So clearly, despite this, when the numbers of people who are asking for help from the health services is rising, there's a need for services. And what's interesting is, with the rise in people asking for this support, tinkering around the edges of the health system, making people work harder, smarter, faster, isn't going to be the only answer. It requires a wholesale rethink of how the health service becomes more accessible, is clearer and easier to navigate, is personalized, and is available for people at the point of care closest to them, which is primary care most often. And shoring up that primary care sector, fortifying it so that it is resilient and can deliver the outcome, is the conversation we're going to have today. Good evening, colleagues. My name is Mohit Venkataram. I'm the Deputy Chief Executive for North East London Foundation Trust, and I'm the host for the Future of Primary Care webinars. As a large provider of statutory health services, we recognized very early that our role in the system was not just about providing the health services for community and mental health care. Our role was also to stitch together and knit the various facets and partners who work. Our role was to work with colleagues in a way that we could provide and re-engineer care and was more robust. This meant working with many colleagues whose sector setup is different. We are very fortunate at North East London and our sister trust, East London Foundation Trust, to be working with some amazing primary care physicians, colleagues, clinicians. But then the resilience of primary care is completely dependent on the clinicians who work there. The corporate support they have is frugal compared to the corporate support many of us in larger organizations enjoy. And ensuring that we could share that support so that together we were stronger, together we were able to deliver better care, together we provided our residents the outstanding excellent care they deserve was crucial. This webinar series is one such attempt to develop a safe learning space using our corporate resources jointly to the benefit of all our partners, primary care, ourselves, local authority, so that together our services are better. Now, of course, when you're looking at promoting primary care, there have been many attempts made. Very recently, there was the attempt about pharmacy first schemes. There's the widening of access through a number of things that have happened, including role diversification for clinicians in primary care. But despite all these schemes, the need for primary care has not just grown, but stayed central to how the architecture of the NHS functions. And this just goes on to show how important primary care and how valued we as the residents of this country find primary care. In the last month, where the data is made available for April, primary care saw upwards of 30 million people in 1 month. Nearly 750,000 were also seen, in addition to this 30 million, by the extended primary care services, which are called the primary care networks. What's fascinating is that we are often given to understand by the media that people struggle to be seen on the day of care. But 45% of these appointments, so of the 30 million, 14 million appointments, were people who were seen on the same day. In a country with a population of 67 million, that means 1 in 2 of us saw a GP or GP services in the month of April alone. And 1 in 5 of us received care on the same day. Where else will we get such amazing colleagues who not only live up to the expectations we have of them, but continue to deliver it month after month after month? 90% of all these appointments were attended. But importantly, 65% of these appointments were face-to-face. 45% of these appointments were done by GPs themselves. And let's just take stock of the fact that over the last few years, we have been talking about reduction in the number of GPs as we have grown the primary care workforce with wider skill sets. Despite that, nearly half the appointments have been seen by GPs themselves. These statistics stand tall for an amazing group of people who, despite all the rhetoric, deliver some incredible, incredible health services. So now, if we could reimagine a health service where primary care was central to how the design of the health service worked, made it front and center to the delivery pathways that allowed us to access healthcare, then would we not be in a place where the experience of every resident was better than it is now? Would we not be in a place where experience of every clinician who works in the health service is better? Because actually it frees up appointments in secondary care so that those of us who need to be seen there could be seen quicker. Many parts in the country, many parts of this country are having these conversations. They're not easy because we are looking at redesigning whole scale the way systems are set up in those areas. And many parts of the country are now in places where they are talking about either setting them up or wanting to roll it out. But there is one part of the country where people actively quote the amazing work that's already been happening about making primary care front and central of how the health service operates, and that's West Yorkshire. I have been to many parts where people have quoted West Yorkshire, and I am absolutely delighted today to welcome our guest, Rob Webster, who's the Chief Executive of West Yorkshire ICB. Colleagues, for those of you who know Rob, you will know he has been the Chief Exec for Leeds Community Trust. He was the Chief Exec of NHS Caldale Primary Care Trust, South West Yorkshire NHS Foundation Trust, even the Chief Exec of NHS Providers. I could probably spend the next hour just talking about what Rob's done. But I think I'll stand tall by just saying Rob was awarded the CBE in 2020 for the fabulous work he's done across the health services. It'll be my privilege to hand over to Rob so he can share his vision of how the architecture of health services and how primary care is playing a crucial role in that delivery in West Yorkshire. But just before I do, can I remind colleagues, we have over 200 people registered in today's webinar. So there are many of you on different platforms because we are streaming live on many platforms. Please use the Q&A button to post any questions you may have so that I can pull out the themes of those questions and present it to Rob. Also, For those of you who've been kind enough to post your questions in advance to me, I will ensure they are pulled through in our conversation today. Rob, it's a delight to have you today. Thank you so much. Shall I hand over to you to share your views on what's happening in West Yorkshire?
Yeah, thanks, Mohit, and thank you for the introduction. I don't think I could live up to that build-up by any stretch, but I will describe a bit about what we're doing here and what more we really still need to do in what is an incredibly difficult and tough context for everybody. I think I probably want to start by saying thank you to everybody who's joined the call. As Mohit said, it's actually sunny here in West Yorkshire, which doesn't happen very often at the moment. And more importantly, I presume you come at the end of a busy working day. And I know what a difference you're making every day and some of the things that you need to deal with, some of which will be hopeful, some of which will be joyous, some of which will be deeply frustrating, challenging and distressing. So the fact that you're here with us today, I'd just like to say thank you for that. And thank you for what you're doing every day. It's probably worth saying that, as Mohit said, I've worked in all different parts of the system. So I've worked in the Department of Health, I've worked in the Prime Minister's Delivery Unit in Whitehall, I've been a chief exec of commissioners, providers, foundation trusts, non-foundation trusts, and national body in the NHS Confederation. And that gives me a bit of perspective. I've also been a charity trustee. This area of primary and community services is a big passion of mine. I'm an honorary fellow of the Royal College of GPs. I should probably make that clear. And I'm an honorary fellow of the Queen's Nursing Institute. And I think that's because of work that I've done with people in the past advocating for what happens right across this country, often behind closed doors in people's homes, and only becomes visible to some people when, the ocean of distress and misery that sometimes exists behind closed doors washes up on the shore of A&E or our hospitals. And it's clear to me that there are miracles going on every single day in our communities. It's also clear that if you look at the data and if you look at your experiences, modern systems need to meet the mental, physical, and social needs of people. And only by doing that, only by tackling multimorbidity and issues around poverty and deprivation, and also stigma and racism, will we be able to meet people's needs in the future. Now, when I was chief executive of the NHS Confederation up until 2016, I argued very strongly that because of multimorbidity and because of those issues around mental, physical, and social needs of people, which general practices see every single day, about a fifth of consultations are to deal with a social issue. About half of them got a mental health component. You see this every single day, this multimorbidity issue. Because of this multimorbidity issue, we're dealing with a population who will never be cured of the issues that they've got. They just live with them. And we're dealing with a population who becomes sicker because of where they live. Now, if we want to take an institutional, annual approach to the health and care system, we will never get to the bottom of those problems of multimorbidity, deprivation, and so on. We have to look at planning in places, organising care in places across a number of years into the medium term. It's the only way, because we know that these numbers are good enough. About 80% of what affects your health, my health, Mohit's health, is to do with the wider determinants of health. Where do we live? Have we got a good house? What's our education? What's our employment? Do we have access to green space? A bit more pithily put, do we have somewhere to live, someone to love, and something to do? About 10% of what affects our health is to do with, can we access healthcare when we need it? And 10%, is it any good? Does it meet our needs? So if we have to plan for these social issues, if we have to plan for these wider determinants of health, we have to do that in places into the medium term, then you need a vehicle to do that. And that's why we've got integrated care systems. That's why I advocated very strongly we needed to plan in places in the immediate term, but through collaboration, if we're going to address issues. Now, whatever people get obsessed with architecture, and they think that changing the architecture is the job. Changing the architecture is not the job. Meeting people's needs and improving outcomes is the job. But having an architecture that supports that is essential. So whether you want to believe in integrated care systems, integrated care boards, collaborations in places between providers or not, you need to recognise that the fact that people with a learning disability die 20 years sooner is a scandal. The fact that if you come from a Black, Asian or minority ethnic community and you have a learning disability, it's more like 40 years, that's an even bigger scandal. The fact that people in West Yorkshire have a healthy life expectancy that differs by 23 years in places like Wakefield, or that life expectancy varies by 10 or 11 years for the general population, or that a male with a serious mental illness will die 19 years sooner. All of these issues need addressing. And, you know, I suspect none of those statistics will be a surprise to you, but they are shocking. And we need to do something about them. So integrated care systems and integrated care boards like the one I run, I think are necessary if we're going to address the mental, physical and social needs of people, but they're not sufficient. They're not sufficient. So in West Yorkshire, we've got 6 councils, we've got 10 trusts, we've got 315 general practices, we've got about 11,000 third sector organisations, hundreds of pharmacies, and so on. And what we try and do is recognise that all of those organisations are part of a partnership. They've got to meet the mental, physical and social needs of people. And if we're going to do that, we have a unifying vision, which is that wherever you live, you'll have the best start in life. You'll be supported to live your life well, and you'll die in the place you're choosing. If you've got something wrong with you, you look after yourself, because you do anyway most of the time, but we'll give you technology and peer support to help. If you have a few things wrong with you, you'll be in a team. That's you, your family, your carer, the GP, the third sector, and the council, and they'll focus on things that matter to you. If you have to go to a hospital, it'll be a local one, but that'll be networked with others to be sustainable. And sometimes you have to go further away because you need really good specialist treatment by experts that'll save your life and give you better outcomes. All of those things will be bought and paid for once by councils and the NHS working together. And as a citizen, you'll be involved in the design, delivery and assurance of those services. Sounds good, doesn't it? I reckon if you read your ICS or ICB strategy, it says that in about 600 pages, but it says that. If we're going to deliver that, though, we need to do real work together to focus on those determinants of health and the big killers. And we need to have a set of principles. So we've got a vision, we've got a shared purpose, which is to improve outcomes, reduce inequalities, manage unwarranted variation, and use our monies wisely. And in doing so, build social capital. And we've got 5 principles that support that. First is we're ambitious. We don't get out of bed every day just to scud along and get by. We want to be ambitious for the people we serve and the staff we employ. Second, it's a true partnership. Everyone's in the partnership. You know, you can't opt out of it. You know, citizens are on the end of our partnership, whether we like it or not, whether you work in the council, the charity, the GP surgery, the hospital, whatever it is. So you're a partner or you're not. We believe in evidence. So we use evidence. We live in good governance. So we're open and transparent about everything. And we believe in subsidiarity. So things get done as close to the person as possible. Now, this is essential because one of the things that national policy and architecture usually believes is that the big thing is in charge. NHS England's in charge of regions, regions in charge of ICBs, ICBs in charge of providers, etc. It's not true. It's not true. So what we believe is that we deal with issues as close to the issue as possible. So that means it's the person first. It's the 2.5 million people who live here who we try and give power to. It's then, if we can't get them to do things for themselves, to do things in their home. If we can't do things in their home, it's a neighbourhood. So we've got 52 PCNs, 52 neighbourhoods. If we can't organise care at the neighbourhood level, then we do it in a place. We've got 5 places. Some of them are very big. Some of them are quite big, but, you know, substantial. If we can't do them in 5 places, we do them in West Yorkshire. And if we can't do them in West Yorkshire, we try and do them in Yorkshire. If we can't do that, then we'll do them in the north and then in England. But most of the work gets done at that micro level by people themselves, and by general practices and by neighbourhoods. Now, if we're going to do that, then one of the things that we've kept in West Yorkshire is when ICBs were created, we still kept giving all of the money to places. So I don't have much of a budget. We get £5 billion. I give all of it away to the 5 places so that they can organise the services that are required in those neighbourhoods in collaboration with the providers to make sure there's a strong connection to the communities and there's a strong connection to the hospitals. And the money is kept in that way, and it flows through the places into the neighbourhoods or to the hospitals. It's not top sliced and given to the hospitals to organise for themselves, because we need to join up care vertically and horizontally. As we do that, we recognise that Bradford, which is the youngest city in the UK, which is a very diverse city, one of the most diverse cities in the country, particularly in the centre, but facing significant poverty, is different from Leeds, which has got the most diverse economy in the UK. It's financially doing incredibly well. It still has a very diverse community, but the degree of employment and investment is substantially greater. And if you live in Wetherby or Rawdon or somewhere like the places that I live, people tend to be doing quite well. So you need to organise the care in ways which recognises that, and you need to do that with your partners. So we've been trying to ensure that we support that sense of care being organised in multidisciplinary teams at scale, using that principle of subsidiarity, and providing additional support to people themselves to self-care, providing support to practices to extend the capacity that's available, making sure that they can then work together in neighbourhoods, not just with other practices, but with third sector organisations, council staff, and outreach from specialists. And then if they need to, operate at a place level and then come together at West Yorkshire level. And in some places, that's incredibly well developed and incredibly successful. And in other places in West Yorkshire, it's just not. It's not yet, because it's difficult, it takes time, and we've got capacity issues. Now, if you look at the contribution of general practice, Mohit reeled off a load of statistics, and I could give you the same ones here. So, in 2023, on average, there were 1.4 million consultations in general practice, 44% on the same day, 74% face-to-face, 82% within 2 weeks, and 41% by a GP. Now that's massive. And the gearing between that and A&E is about 17 times. So 17 times more people seen in the daytime in general practice than in A&E. So if you get a tiny tweak in general practice, it's a big problem within the hospital. So we have to recognise that. Now in 2024 so far, on average, it's 1.47 million people seen. So it's going up substantially. It's 72% face-to-face, 44% still on the same day, about 40% still with the GP. But we have massively increased in a single year the number of additional roles in general practice. It's gone from 890 to 1,374. So we're putting more people, and we're trying to be as flexible as we can around that. And we've tried to ensure that that's under the control of general practices working in those collaboratives. What I could also point to is the fact that satisfaction levels within general practice are still very high compared to the rest of the NHS, but the dissatisfaction levels have increased substantially. And although 13% of people may be dissatisfied, and that might not sound a lot, when you apply it to 1.47 million attendances a month, you can see you start to get to a big number and quite a lot of unhappiness. Now, we've been doing some work around why is this the case, and how can we help? So the National Primary Care Access Recovery Plan, good. It's good to have additional capacity. It's good to sort out the primary-secondary interface. It's good to sort out issues in terms of telephony. So that's all good, and it's good to get those additional roles and to provide some additional capacity. But we've also done some work with the South Bank University and practices in Bradford to share across West Yorkshire on what's going on in those communities where people are either distant from care or they are unhappy. And what we've found is there's some really interesting things going on. So we're medicalising poverty. It's part of the problem. So people are dissatisfied because we can't deal with issues they expect us to deal with. Or if we do, we're giving them the wrong solution. It's also the case that a flat offer is not a fair offer. A flat offer is not a fair offer. If you are in a low income household with 2 jobs and a chaotic lifestyle, and you want to have this, we can't give you the same offer as we would if you're a white collar manager living in a decent house with time to organise your life and few chronic conditions. We need a different approach. So we've been looking at how do we build experiments in different places which will provide different ways into services and a different response, which meets your mental, physical or social need. And using the work that we've got around health inequalities in Bradford, trying to hardwire that into the way that we work and give people the freedom to do the work themselves, to create those services in ways which are going to meet people's needs. Alongside that, what we've been looking at is what are the other barriers that we've got in place to delivering good care, which starts from people themselves into homes, general practices, neighbourhoods. And our estate strategies at the moment, we're doing a big audit of what does the estate look like in primary care. You know, we've got something like, I've got some numbers here somewhere. We spend about 50 million a year on the general practice estate. It's about 14% of the occupied space from the NHS. So it's a substantial amount of building across West Yorkshire, but there's about 4 million quid of backlog maintenance. And we've got substantial problems when it comes to, do we have the space to do what we want to do in West Yorkshire? And there is a substantial gap in the National Capital Programme where small and medium-sized schemes should be and where primary care schemes should be. So we're working to see in each of those neighbourhoods what's available and how would we create the space through our partnerships to deliver care that meets the needs of people, using all of the skills from the community organisations in the NHS, general practice, the third sector and others, so that we can meet people's needs. Because in estates in North Halifax, it's the fact that the debt collector has got hold of you owe someone 500 quid as a single mum that's leading you to substance abuse and stress and anxiety and coming back to the GP constantly. Working with a credit union, ensuring that you can clear people's debts quite quickly and move them towards greater control is a way through that. But you need a space for the credit union, you need a space for the primary care practitioners, you need a space for the trusted partners so that people can open up. So we're looking at all of these issues about where do we get the estate, where do we get the IT and the information. So in Calderdale and Huddersfield Foundation Trust and the surrounding practices, there's really good interoperability between the systems. How do we roll that out across all of our systems? How do we use the Yorkshire Care Record to do that? And how do you make sure that people have always got access to good IT? The rollout of the NHS app is going well for us. And we know that that's something that we need to deal with. And we need to wrap this up in something which is going to set out a vision and ambition and a framework for primary care in West Yorkshire, which embodies general practice, pharmacy, dentistry, and all of the surrounding services in that model of care, where we start with the person, go with the practice, go to the neighbourhood, think about the place, and then connect that into specialist bed-based services. But ultimately, we've got to do that in a way which focuses on prevention, secondary prevention, and keeping people as well for as long as possible, and trying to meet their needs, because ultimately we're a guest in their lives. All of us are guests in people's lives. And if we start to think like that, and we recognize that there are other people who are guests in their lives too, we can start to organize care in ways which meets their needs and stops us medicalizing poverty, stops having unequal approaches to care, and starts to reward practices and practitioners for the brilliant work they do. Because my belief, my very strong belief and advocacy, is that general practices, there's a strong narrative at the moment, isn't there, amongst some commentators that the NHS is really unproductive. And I say, well, is it? Which bit are you talking about? Because primary care isn't. Primary care is doing more work. GP numbers are flat or falling in some places. Not for us, they're flat for us. Got more staff overall because of the additional roles. But it's more productive. And every time we ask primary care to respond, it responds. So let's think about the flu season this year and the COVID vaccinations. The rules changed every week. There was a 2-week period where the rules changed. Everyone mobilized and got on with it. Because the response from primary care is always magnificent, and it's always connected to their population. And this is one of the things that I think we've got to maintain at all costs, and we're at risk of losing. And that is the social contract between general practices and people. So I think that's embodied in the way we speak about GPs, because people say my GP and GPs say my patients. It's a pretty simple indicator that social contract exists. And people still, I think, have an understanding what general practices do, although I don't think they understand the broad array of what's available now, the different people who work in primary care, and the way in which we can help them. But let's hope that we can. And I hope that has given you a bit of an indication of what we're doing. I think it's worth saying that we must get to a point where primary care and general practices particularly feel valued by the system. And here I mean the national system and politicians. They should be, in my view, the strongest champions and advocates for general practice. It doesn't always feel that way from the media, and it may not always feel that way from some of the settlements that are made around the contract. And we've got to change that. We've got to get into a position where there's a clear national vision and ambition for primary care that goes beyond access and values what people do. And I think we've got to recognise that national policy, I believe national policy in line with the vision and ambition that I've outlined. National policy is in line with integrated care systems, integrated care partnerships, integrated care. And you can't integrate care without good, strong general practice. So I'd like that to have a lot more airtime nationally. Happy to get into a conversation if it's helpful. I think you said 20 minutes or so. I've probably gone on for that.
It is absolutely brilliant. And I think what you've shared has been so pertinent, Rob, because we have always focused in this webinar on good practice in primary care. But seeing primary care as part of the system and hearing the Yorkshire story of how it's being placed is really fascinating, because you're spot on. Primary care has always played its cards really well. They have delivered. Their productivity is high, hardworking group of people who have done absolutely everything that's been asked of them. It is unfortunate that people get focused on a few areas without recognizing the extent of impact the demand is having on primary care, and it continues to still deliver. You're also spot on, because it's rather sad when the national settlements don't fall right for primary care. I mean, it's really fascinating. We all have this conversation about how capital is a big problem for every part of the NHS. It's not just for primary care. But actually, it's much worse off in primary care. There's absolutely no CDL that's allocated specifically for primary care. And what is allocated is so minuscule that the ability to pick up backlog maintenance is horrible. And when I speak to GPs, there is all this investment about new stuff, new roles that are coming into primary care. But where's the space? Where's the leadership capacity to give them the support? So there's expectation to take them in without the time and efficiency and the corporate resilience that's required around that. And I think that's one of the reasons trusts like ours are stepping in to saying, actually, if we share our corporate resources, we are in a much better place, stronger together than we are alone. I think there are a couple of really good questions that are being posted. And John, I mean, he's from Yorkshire. You'd know him. He's one of the chief execs, posted around anticipatory care. And I think while he talks about anticipatory care and the impact it's having on primary care, I think the question is much wider than just anticipatory care. Modernizing and transformation of primary care requires a culture change from partners around, not just primary care culture, but wider partners to recognize their role in supporting primary care to make it happen. And anticipatory care is just one such example of much wider thing. So what's been the experience in West Yorkshire in trying to get that culture right across all partners to then think through how does the growth of primary care actually support the system and provide that resilience?
So I think there's, as ever with a system our size, there's a really mixed picture. So if I was to talk about Wakefield for a second, I would be able to describe, I think, a system that's doing some really good things. So in Wakefield, you've got a group of primary care networks which are well connected to their practices. And Wakefield in the five towns, it's a post-industrial, post-mining set of communities with low life expectancy, high obesity, a very broad gap in healthy life expectancy, and some substantial issues around mental health and well-being of the communities. But in Wakefield, we've got a set of people who've spent time, effort, and energy on how do we build integrated teams, and then how do we work collectively across the interface, and how do we lead together and decide together on the use of resources. So that the way I describe I give all the money to the place in Wakefield, the place committee is chaired by a GP who's a very experienced GP, and she's absolutely fantastic. And the Connexus, which is the GP Federation, is owned by, in a meaningful way, all of the practices and the PCNs. They believe they advocate and support what they're doing. So if you need anything done quickly, you've got around the table when you're talking about the system, and you turn to Colin Spears and his team and say, look, Colin, we need primary care to do this, or what do you think we can do through primary care, or how's primary care feeling it gets done? Because you've got GP leadership of the committee, you've got GP leadership of the provision, you've got strong primary care networks, and you spent a lot of time on the culture. So we had some investment about 7 or 8 years ago on the team of teams approach from Stanley McChrystal. That worked really nicely. What we've also done is that work on the primary secondary interface. Wakefield's the best and most mature in West Yorkshire. With the trust, we've worked systematically through a range of specialties to look at how do you have shared care, which goes beyond advice and guidance. So that what you're doing is you're creating a team between the primary care clinicians and the secondary care clinicians, where you can do some quick review of what should happen to an individual. And that shortened the time and response, prevented referrals, and also seen a reduction in tests, diagnostic tests, and increased capacity within the system. It's probably meant more work for the hospital clinicians rather than primary care, strangely, because everyone thought you're just going to dump on general practice here. It hasn't quite worked that way. But people have seen that by working together and doing that work, then that works incredibly well. If you don't have if you don't have one of those elements, it's going to be suboptimal. If you don't have somebody representing primary care at the place committee, if you don't have good primary care leadership of provision that's connected to the PCNs, if you don't have strong PCNs, if you don't have good practices, then that starts to fall apart because you don't invest in the relationships. So what I see in other places is you get into a conversation of, can you stop sending us this stuff? Stop sending us these duff referrals. Well, stop dumping on us all of this anticipatory care or these medication reviews, or sending people out with drugs that we don't understand, or putting them on the wrong drugs that you get a good deal for and we have to buy something else, all this stuff. And, we can all do that. We can all do that, can't we? We can do that all day. The better conversation is, can I just explain to you the impact you're having on me in the way that you're doing things? And can we have a conversation about what impact I'm having on you? Can we do something different? So we've tried to invest in that kind of thing with significant leadership. But if you don't do the OD work, it really doesn't work. And if you want to get a bit tougher about it, cynicism, don't confuse cynicism for leadership. So if people are sitting around whinging and saying everything's terrible, and okay, what are you going to do about it then? What are you going to do about it? Do you want to be cynical and defeated, or do you want to try and change things? If you're met with cynicism and defeatism, then you've got to try and find a way through it. But you can only do that by working together.
I think that's correct, and I think it was really heartening to hear the effort being put into developing leadership capacity in primary care, because actually the reality is acute sector, mental health, community sector have over the last 20 years had a lot of investment in developing leadership capacity.
Yeah.
We've not done that for primary care. So expecting our GPs, who are pretty intelligent people who have gone on to become doctors, or expecting nurse practitioners who are extremely experienced, or pharmacists working, to then stand up and have a voice and recognize how to leverage the corporate architecture for their benefit is missing. So that investment in leadership is really the crucial way of getting this right. And how many people have been through that kind of a leadership support program in West Yorkshire so far, Rob, over the last few years?
Well, it depends which context you're talking about. So we've got a very broad range of supports. One of the things we're trying to do through the Access Recovery Programme is to put as many practices through a kind of OD support.
Right.
And about half of practices, I think, have now signed up to that and been through some elements, but much more needs to be done. In places, there are different arrangements that they've developed themselves, and then we supplement that with things like our fellowship programs. So we have fellowships for health inequalities, for racial equity, for climate, for suicide prevention, and we're on the 4th iteration of those now. And we have primary care professionals, we've got social care professionals, we've got people working in the third sector and so on those fellowships. What they do is a 1 day a week piece of work on inequalities or climate change or leadership and development around diversity, which then feeds into the work of the organisation. Because we've recognised that on health inequalities, this started in health inequalities, and what we started with was, we can all describe the situation that we're in now. I've done it myself, haven't I? We describe the situation we're in now, which is people learn disability die too soon. Describe the future we want to get to, if that doesn't happen. But what happens in the middle, where you need insight and you need capacity and capability? So we've put hundreds of people now through those fellowship programs where they build the insight, capacity, and capability, and that includes people from general practice and primary care.
And there has to be a recognition, isn't it? What we are trying to do is to level the playing field for primary care to have a voice, but we will need to give it time too, because actually mental health and acute sector have had it for 20 years before they've now come to a place where different. So it will not happen over the next few years, but actually if we keep investing in that primary care capacity over the next 10 years or so, we will expect. And so the story you say is one story that we'll probably hear over years to come.
Yeah,
which will
I
show
think
that build up happening. So it's really brilliant to hear that.
I
And I
think
think what's
sorry,
the other thing that's
sorry,
standing
Margaret.
out?
I would just wanted to reflect that I couldn't talk about this without recognizing that, the abolition of clinical commissioning groups has significantly diminished the role of general practices in commissioning. Just excuse me a second, I need to plug this in, otherwise I might just disappear unexpectedly.
The joys of technology.
And what we're transitioning to at the moment is, if you had a set of decisions which were overseen and approved by a group of general practices, and now you've got committees of the ICB in places, or across West Yorkshire now, a set of arrangements, there are fewer GPs involved in that. So it may feel like there's less ownership and leadership of general practice at that level. So we're trying to create, with the 52 clinical directors, a cohort of people who feel that they've got an opportunity to make a difference. And where we've got really strong primary care confederations, that the capacity and leadership there is, it's much more powerful to get the delivery done and be in charge of the resources and the delivery, I think. But that transition will take time for people to feel it.
And there are a couple of questions here, Robin. I think this is the harder one, but it's the one where you lead on to a few years down the line. Have you, in your experience, and this journey of West Yorkshire has just started about 2 years ago, so it's still infantile compared to the history of the NHS where we are. Has there been the opportunity to start seeing the money swing towards primary prevention, primary care, investment in community services, so that there was actually so that there was appropriate utilization of secondary care? Because often we see patients there as a consequence of not having had support early. It doesn't mean primary care was poor or community. It's just that access has not worked for that particular patient. And given the width of the spread of what you're managing geographically, I would expect there to be an impact. So have you seen yet any of that change of financially money moving into primary care or community services?
This is a tale of, I think, three periods, really. So the first period, when we came together as a partnership in 2016, so that's how long STPs and ICSs have been going, our first strategy said we will disproportionately invest in mental health and primary community services. So growth will be greater in those services up until each year in the strategy. And we started to see those changes and those moves. And some of that's because of the prescribed monies around, additional roles, etc. And some of it's local choices and decision making. And a good example, which is around the broader team, I guess, in primary care, is that in previous years, we have taken money from hospitals. Hospitals gave money up to give to social care to pay staff the living wage early, so that it would prevent staff from leaving and going to work in Amazon. Because you could get £1,000 sign on at Amazon in, just off the M1 corridor. So we knew that increasing the basic wage and giving people a sense of value, we valued them, so we're going to pay them better, was important. So the hospitals gave money to social care because they knew that was the right thing to do. Similarly, we've put money for urgent care into communities to tackle loneliness through the third sector. And that came from urgent care at the behest of all the partners. So we've done these things, and we've had a strategic ambition to make that the case always. COVID, so the second phase, COVID completely. So our finances in 2016 weren't as good as they were by the time we got to 2019-20. We achieved our financial targets every year, but by the time we got to 2019-20, all of the organisations but one were in surplus. And we were much healthier because of that openness and transparency in these more resilient systems. COVID period, obviously money just got allocated There was a lot of money put into hospitals. It's really skewed the way that the money's worked. And we did that in the right way, and we invested in the right way, I believe. And now we're coming into the third phase, which is how do we reset all of the finances, and how do we get back to our ambition of the left shift of resource and the left shift of services towards primary prevention and towards secondary prevention and integrated care in communities can restart. But we have to reset the service and the system.
And that's a really fair comment, Rob, because that's happening nationally. Everywhere in the country, we're seeing the need to reset and rebase and then re-energize the system to recognize what's right. But I think it's brilliant to hear from you about the work that's been done to have a differential investment program. So primary community services were invested in with an active involvement from the acute sector, because this is not one against the other.
Yeah.
This is about recognizing what's right for the resident and making sure every part of the system then gets the right answer for what they are trained to do. So it's brilliant to hear that, because there are very few places which have been successful in being able to alter that. So it's really nice to hear. And what was really good to hear was when we talk about primary care, it is the width of primary care we are talking about: community services, social care, voluntary organizations, the nursing cadre, the community.
Yeah.
Because if we forget that, actually the GP practice by itself will still fail, however much you invest in them alone, because they would still not have the network. So I think that is the kind of answer. I think the part I'd like to go back and touch on is, and one of the colleagues has raised that question very actively, the role of volunteers in the health service is still rather rudimentary in a country where we have put in so much of effort into developing systems. And there are so many passionate people who do an amazing job. And volunteering is not for the reason of getting paid. It's actually the meaningful ability to to contribute to the community you're part of. And there are colleagues here. I mean, Jamu specifically, I mean, I've known her for years, and she's one some people I respect like mad. And she raises the profile of the role she does. Has there been any thought given about the role of volunteering in the
Yeah.
whole health service provision there?
Of course. I mean, I think if you look at organisations and volunteers, then you can see loads of good practice. So in my own, the last trust that I ran, Swift, we had a central volunteering hub. We provided support training and types of supervision for volunteers, and we ensure the roles created for volunteers. And we started that from the induction of staff and into service planning, etc. The bigger point is that when you look at the workforce strategy in West Yorkshire, we talk about all of the staff within the workforce, all of the volunteers and all the informal carers. So for me, what we talk about, our people are the 100,000 people who work in health and care. It's I think it's something like 400,000 people who care for somebody because they love them or feel a sense of duty towards them. And then it's the 100,000 or so people who volunteer in West Yorkshire. And what we've got to do is think about how we're using all of those assets. If you go back to my original comments about people with multimorbidity living in deprivation and poverty, then often they have informal carers and unpaid carers, which are family members or belong to charities. So we've got to see them as part of the workforce, and we've got to have a systematic approach. And I don't know if you've seen it, Professor Jane South did a nice piece of work on volunteering some time ago. She's from Leeds University, which said that people think there's a kind of hierarchy. So doctors like yourself are at the really skilled and at the top, and then there's nurses and allied health professionals who have got a slightly narrower scope of practice. Then there's unregistered staff who are trained but not professional, and then there's kind of people who help them, and then there's volunteers who can kind of show people around or make a cup of tea. Her role, her work said you should never think like that. people have different skills, and volunteers, actually, you can stratify the skills that volunteers have, which tend to be about enterprise and empathy. And you can think about how that fits into your team. And if you take that mindset, then you'll end up with a different type of team which can meet people's needs. And for every clinician like yourself who is approachable and open and people feel able to have trust and confidence in, there'll be people who are scared of a professional who won't feel scared with a peer or a volunteer, particularly in mental health or maternity or other services. So yes, in short, yes, we have a strategy that involves volunteers. We have an infrastructure in some places that supports volunteers. We need to always see volunteers and informal carers, I think, as part of the workforce.
Brilliant. And I think, Rob, we are inundated still with questions, but we would not have the time. And given I am hosting, I have the prerogative of asking the last question. So I'm going to, colleagues, I'm going to bring in the question I want to bring in. Given your experience of leading this from 2016 and building an architecture and a system that's different from elsewhere, and clearly it's a journey you're on, and the journey has to continue for years after this to truly find the answer. Today, 7 years on, if I was to ask you what are the two things, if you were given the knowledge you have today to restart 2016, that you would say, that's the two things I would push for most without a doubt, because that really makes the biggest difference, what would they be?
I think it's difficult to say, isn't it? It's what the two things I value the most, I think I would say, is you've got to, progress moves at the speed of trust. And if you don't build trust between people, whether that's patients, people, and practices or different parts of the system, if you don't build trust, you're not gonna make change happen. So that focus on trust and building that. We spent a lot of time at the beginning just doing work together to do that. And I think people are saying, well, what are they actually doing? And then once that trust is built, we move really quickly, but it takes time and you've got to invest in it. And then good rules. Good rules. If you cannot make decisions, and if you're not working on stuff, then what's the point? So I think if it was to add a third, real change. I've learned that real change happens in real work. Do some real work. Do that when you've built on some trust, and make sure that you've got good rules so you can make decisions.
Rob, it's been an absolutely fabulous hour. I can't tell you, there's so many things that have chimed today, and just how abuzz our Q&A section has been with questions shows how much it has shined with many people. And the things that evoke that active involvement is what we are looking for on these webinars. I mean, the fact 200 people have registered, the fact that we spoke not just about primary care, but recognizing the wider determinants of health, which is where primary care is often challenged. And there are questions around colleagues having friends who with broken shoulders, and they're repeatedly going to primary care for help, but actually the support they need is for that financial support. And you recognize that with other examples you spoke about in West Yorkshire. I think the fact that we touched on, we are looking at tackling poverty, but we are tackling the racism and stigma that goes with much of this happens in the communities, recognizing that we have to personalize care in a way that it makes sense. It's been absolutely fabulous. And I think these webinars have already been one that have spotlighted the best practice, have spotlighted primary care at its best in so many ways that it's really, really chimed with people. But today was one of those seminal moments when primary care came on its own across the whole sector to say, actually, I have a position on center stage. And I absolutely loved hearing that bit, that journey that West Yorkshire is on. I can't thank you enough for your time, Rob, today. It's been brilliant having the time to talk to you and to hear the story of West Yorkshire. Clearly, colleagues who are online and for those of you who have registered, there is no webinar that happens without you all. It is your active participation that really makes a webinar so much more meaningful. And today, with all the colleagues who have joined, from managers to clinicians to well-meaning intentions and people who are volunteers, and as Rob said, who are often seen in the system as they are also there to chaperone. I think we've shown a spotlight to recognize we are all in this together. We only make a difference. But the importance of recognizing this is about trusting each other in the system so that we are not looking at resources as people, as organizations, as contracts, as hours, but they belong to the residents. And how do we come together to find the right answer for them? It's been really positive, and I have absolutely loved the session today, talking about the architecture. So, Rob, a big, big, big thank you to you. An amazing thank you to your partners whose story you've shared today with us and those who could join us and ask the questions. A big thank you to all of you online today who have registered, because we're so close to the summer and the weather is so lovely that even I would like to sit outside and still enjoy the sunshine, but you've all agreed to still hear us. I'm hoping you're doing this sitting outside in your gardens or in the parks close by. I think a few big thank yous also to people like Jamu, who I'm sorry you've had a difficulty logging on. So please say thanks to Norbert for sharing the links with you, and we'll make sure for colleagues who couldn't get the link this time, it's easier. A big thank you to Kelsey and Alice, who in the background really make this work so smoothly that you sit back and think, oh, I'm running it. But I promise you, colleagues, it wouldn't work without Kelsey and Alice telling me exactly what to do and when to do it. So I'm very grateful for their support. Kelsey's put up the QR code. For those of you who here, please do scan this and post your feedback, because it's really important for us. It helps us build on the next webinar, and the feedback is a key part of what we do. You all know, colleagues, that we do this on a monthly basis, but the month of July is one of the months we skip because it is most often the time many of us are away. So I wish you all an absolutely amazing summer. Hope you have a great time with your families, and hope you don't have to use the health services in the best way possible, despite all of us working there. Have a great summer, and I'll see you around in August with our new lineup of speakers.